Hello everyone, and thank you very much for tuning in to this talk. In the spirit of the open sessions, this is very much work in progress, and so any comments, feedback, or questions, I very much welcome. My talk is going to proceed roughly as follows. I'm going to first outline the background to the question and why I think it's a salient problem that requires theorizing. I'm going to then explore two solutions that have been proposed, and why I think they are inadequate. I turn to a third option, which I call the expressive function view, and why I think it captures a lot of our intuitions and considered judgments about the topic at hand. I then take stock of the argument and some of the limitations, and possible next steps for developing this argument. Without denying the controversial nature of health, I want to accept just a working definition at the outset. I propose to define health simply as a state of normal physical and mental functioning by reference to the species baseline. And this is quite familiar from theorists such as Bors and Daniels. Health care, in contrast, is the practice of providing clinical care by health professionals for the sake of remedying, mitigating, or managing illness and disease and improving or promoting health. And this is the kind of topic that is seen as the domain of the health system. So we think here of doctors, of people working in hospitals, of people working within the health sector. The social determinants of health, on the other hand, which has received renewed attention in the past few decades, is the broad social factors, political, economic, and cultural factors that influence health. And these range from education, to social capital, to housing, to class, to even the kinds of relationships that we have with our partners. All these impact on health, and this is seen as the domain of policy, politics, or kind of personal lifestyle choices to an extent. And this is the kind of background that we are addressing, especially in contrast to health. The problem is that we have intuitions about the value of health. We also have intuitions about how we ought to promote health. But often these conflate interventions aimed at the social determinants of health and interventions aimed at promoting health, but they don't necessarily address the value of health care itself. And so it's not clear whether we're talking about the ideal of health that's important or about the practice of health care itself. And I think this is an important challenge because, as I will show, our answer to whether or not we value health or health care determines a lot of the social policy. We may well imagine, for example, that if our goal is health, then there are other ways of achieving this short of health care. And so in what follows, I'm going to articulate what I think is the moral significance of health care, rather than the broader notion of health, or the kind of social political interventions aimed more broadly beyond the health system. And I hope to show along the way why I think this is an important question to address. The two common views in this topic are the biomedical and the indirect view. The biomedical view, which is what we might call a common sense approach, is that the moral significance of healthcare lies in its ability to promote our health, so as to alleviate, manage, or minimize illness and disease. And this seems fairly true of why we value healthcare, at least when we speak to lay people. The indirect view, and the most notable philosophical proponent of this view is Norman Daniels, argues that the moral significance of healthcare lies in its ability to promote some broader notion of justice, for example, well-being or opportunity. And so here the point of healthcare is not just the alleviation of disease, but the promotion of something beyond that. In the case of Daniels, it's the promotion of a normal opportunity range, and thereby the realization of fair equality of opportunity. There are in turn ways that we can conceive of this distinction, of these two positions. First, we might distinguish between a strong and moderate variant of these positions. On the strong one, we might say the moral significance of healthcare lies solely in its promotion of the ideal in HC1 or HC2. On a more moderate variant, we might say it lies primarily, but not solely, in its promotion of the ideal. And I flag this up merely to show that both these positions, whichever one we hold, applies and can be analyzed using the framework that I'm going to outline. We should also see that HC1 and HC2 are not mutually exclusive. It is consistent for us to value both the ideal of the biomedical approach and the indirect justice promoting view. Indeed, we may want to predicate HC2 on the achievement of HC1. That's to say, it is only through the alleviating of particular ailments that we allow ourselves to experience opportunity. And so here we have a kind of ordering approach, but where the ultimate goal is HC2, but predicated on HC1. This seems to be, to an extent, Norman Daniels' view. There are many, many issues with the biomedical and indirect view, and I want to address some of them and why I think we should revise how we see this. It should be clear, though, that my critique of the biomedical and the indirect views, my core critique is not that they're irrelevant. I think they actually capture a very significant and even a necessary component of what makes healthcare significant morally. What I want to argue is something more modest, which is that they are incomplete without tracking a more fundamental aspect of healthcare. The claim is that HC1 and HC2 alone cannot actually establish the moral significance of healthcare, rather than the broader notions that often go hand in hand with this debate. There are many ways in which we can motivate this critique. The biggest challenge, and I'm just going to flag a few, against the biomedical view is that we now know from robust empirical evidence over the past few decades that healthcare is extremely limited at determining health outcomes, especially at the population level. So if we cared about promoting health in the population, we would invest our social capital, our investments in finances, into the broad upstream interventions such as housing, education, income. Because we know at a population level, creating a healthy environment in terms of the social policy is much more significant in promoting health than the provision of health care in a hospital. And this is counterintuitive for many who don't work in the empirical area of health. But this is now more or less accepted. Indeed, it was why Norman Daniels rewrote Just Healthcare to Just Health in the later iterations of his work. Against HC2, the indirect view, we have a problem because it may be that we can promote the good, for example, welfare or opportunity, we can promote the good that it's concerned with by bypassing healthcare totally. It may be that we can promote welfare, for example, through more effective non-health means. Buying everyone a house, giving them a free Porsche, chocolates for life. These are all welfare-enhancing interventions for most people. And it may be that this is more cost-effective and more effective in general than providing vaccinations or particular health interventions. We also know from evidence about how people trade off their health for other welfare or opportunity-enhancing experiences that it's not clear that healthcare really is the way to promote this good. We frequently go to bigger cities with more pollution to have higher-paying jobs. We go skiing despite the risk of significant health injury. We do this because we value the goods that the HC2 is promoting, for example, welfare, independently of health, of healthcare as well. And so what's clear is that if we value HC2, it may follow, or it may be an implication, that we can promote that particular end result more effectively outside the domain of health. And so we then can't capture what it is about healthcare that is distinctive and significant. And so from here, it needs to be the case that we need to ground healthcare on something more stable, something that is closer in link. Remember that HC1 is prone to the empirical objection that there are other ways of promoting health beyond healthcare, more effective ways, in fact. And HC2 is vulnerable to the instability of promoting the ends independently of the means. So we can promote welfare or opportunity or whatever metric of justice we prefer by bypassing healthcare. Now, it should be clear that I'm not making the claim that the biomedical and the indirect view are irrelevant for the moral significance of healthcare. I actually think they're very important. But so far, the argument is simply that they're incomplete. And if we rely on either or both of them alone, we will find that we can't actually justify the significance of healthcare. I want to propose a third way of which we can conceive this. And I call this the expressive view. The moral significance of healthcare lies in its ability to express respect to individuals in a morally salient and distinctive way. And again, I emphasize that this does not mean that HC1 and HC2 have no role to play. Simply that the expressive function operates in addition to or over and above the other aspects of the significance of healthcare. This issue has received significantly has not received much attention in the literature, and I can count on one hand the number of articles that have addressed this issue. That comes to mind, for example, Daniel Weinstock, Kristen Voigt, and Guy Wester, to an extent. And so beyond these people, the expressive function of healthcare has been under-theorized in this field. The question then becomes, though, how does healthcare express respect? Because this seems to be an important link in my argument. And the first way it expresses respect is its focus on the individual. For example, this is in particular against the HC1 criticism of the social determinants of health. So unlike the social determinants of health, or the way in which population health interventions can focus at a broad group level, healthcare tends to focus on individuals in flesh and blood. It's not about a mere statistic in an epidemiological analysis. And this can be important for giving salience to individual claims and individuality. For example, when we benefit from a large-scale diet program or exercise program to prevent cardiovascular disease, the benefit we get from that is much less distinctly individual than if we're treated by a paramedic and then rushed to the emergency department to get medical care after a bad car crash. A second core feature of how healthcare respects individuals, and my main argument, is its link to our personhood. And I trace this in a number of steps. But firstly, we have to acknowledge the kind of reality of universal vulnerability. And this is just the observation that humans are intrinsically, inherently, and universally vulnerable. We are one accident away from an injury. We're one policy vote away from destitution. We're one mutation away from cancer or other serious illness. And this grounds a kind of reality that operates in the background that is significant. And notice that even the richest and most powerful tycoon, the richest person, is subject to the reality of vulnerability. The rich politician can equally get cancer. The rich businessman can be hit by a car at any time. And so if there's any variation in vulnerability, it's a matter of degree rather than kind. Now, of course, the matter of degree can itself be an injustice and an issue for theorizing. But what I want to show at this stage is that the mere presence of vulnerability itself is a morally significant fact, independently or in addition to the differences in vulnerability. And so on the expressive view, the link between vulnerability, personhood, and respect and healthcare is very important. We can see this in two different links in turn. The first link is a kind of simple, direct strand, which is that healthcare directly addresses our vulnerability. And when it does that, it addresses a core aspect of our personhood. When we're ill, when we're injured, healthcare provides us with the means to reduce our vulnerability here and then. When I injure myself, healthcare provides me with a particular mode that reduces my vulnerability in that moment. And that means that by reducing my vulnerability, which is a key feature of my personhood, it respects that very aspect of what characterizes me as a person. In this case, the universal and inherent vulnerability. In another way, it also provides us with the goods to reduce our vulnerability. And this is a kind of agential approach to healthcare's expressive function. When we walk around the streets, when we ride a bike, the knowledge that healthcare is available to us, should we trip and fall, should we have an accident, gives us the strength and the permission, the ability to pursue our agency. And that, again, traces back to the inherent personhood that I think characterizes us as human beings. The second mechanism is what we might call the conceptual strand. It's a slightly more abstract argument, but we might simply think that healthcare is simply the conceptual requirement for respect when we view the reality of our vulnerable personhood. And here we might make an analogy between a sort of fragile Fabergé egg and the rugby ball. If I have a rugby ball, I can kick it around, I can throw it without contradiction about its purpose and its form. It's simply part of what a rugby ball is, that it's kicked around. But compare that with a very delicate, ornate Fabergé egg that's, vulnerable in a sense. We wouldn't go around kicking this egg or rolling it around. We would take care in handling it. We would cushion it. We would take care to store it carefully. And so on this argument, the provision of healthcare is simply the conceptual requirement for how we would treat or how we would show respect for a vulnerable entity that is a human person. And so in the same way that how we treat the Fabergé egg is given by the very concept of the vulnerability, we can make a sort of parallel argument for the human being. In the same way we wouldn't punch a human being in most instances, or do particular actions that breach this vulnerability, so too we would not do this to a Fabergé egg, and this is a kind of conceptual demand of healthcare. It's a kind of conceptual demand, of how healthcare provides us with the tools to respect the personhood. And we might draw here a parallel with the demand of recognition respect. It's simply what we're owed qua moral agents deserving of respect. And so here we might take stock of the argument and go back a step and say, healthcare has important functions. It reduces illness, per the biomedical view. It promotes other metrics of justice, such as welfare and opportunity. And this is true, but a core function on top of this is that it expresses respect. And so even if healthcare does not provide the most important way of reducing illness at the population level, to the individual in flesh and blood right now, it is a way to respect them and their vulnerable personhood. It's a way of recognizing that in flesh and blood they are a person who's vulnerable. It's a way to reduce their vulnerability, to promote their agency. And it's demanded by the kind of concept of respect, just as how we would treat a Fabergé egg entails certain limits and norms. How we treat people may entail the provision of healthcare, simply to respect the reality of that vulnerable personhood. So let me take stock of the argument that I've explored. My argument, to make clear, is that the expressive function operates alongside the biomedical and indirect function. Indeed, if the biomedical function were not present, the expressive function would not work. because part of the expressive function is precisely its way to address our vulnerability. But this is a different claim from saying that the biomedical view is the very point or the very sole end or primary end of healthcare. It is at most a very important sphere, and it provides an important factor for how we can reason about the significance of healthcare. But on its own, it's not sufficient. So too with the indirect function. It is not sufficient to say that it promotes another good, such as welfare or opportunity, because it's unstable and can be promoted directly by bypassing healthcare itself. Again, none of these arguments are mutually exclusive, and indeed, my own view is that all three are valuable. There are other limitations that we need to address. Other vulnerability-reducing goods, such as income, social welfare, these can also reduce vulnerability. And so am I committed to the view that these are equally important? Well, the first thing to note is that I think they are important, and they have a significant role within an egalitarian or liberal state. But it's a different claim, I think, because unlike the requirement for income, healthcare is a much more fundamental aspect of our personhood. Income and our need for welfare is in a sense socially contingent on a capitalist economy or a system in which we need particular funds to buy the essentials of living. On the other hand, for as long as we're subject to the vicissitudes of biomedical forces, of our bodies, then healthcare will continue to be something that's intrinsic and a core requirement of our personhood. And so healthcare seems more connected to our personhood than do programs relating to social healthcare, social welfare, and income. Again, not to deny their importance. I should also say that even though these three views are the ones I've explored, I don't hold the view that they're exhaustive of the importance and the morally significant features of healthcare. On the other hand, we may well consider other important roles and functions that ground the significance of healthcare. I don't address them here, but I can make the point that regardless of these functions, it seems clear that the expressive function will nonetheless play an important role, at least given the particular social meaning that health occupies in our society and the reality of our personhood. And finally, it's an open debate whether a universal provision in the sense of, say, universal healthcare or egalitarian provision is a requirement of this. My view is that it is, but I don't make this argument in the interest of space and time. In the same way that respecting the Fabergé egg requires that we treat all of them, all the eggs the same. We can't decide to kick 2 Fabergé eggs and just look after one. It seems that the conceptual requirement of respect entails that we treat all of them the same. So to respect people's personhoods, given that we're all the same universally, in the way that I've established with our vulnerability, it seems clear that we have to take a universal approach to how we provide healthcare. And this, I think, captures an important way of thinking about healthcare. To say that the social function is as important and operates alongside the biomedical and the indirect functions. As I said, though, this is all very much work in progress, and I thank you all for listening. Any comments and questions are very welcome, and you can email me or visit my website to give feedback or to chat about these issues further. Thank you very much.